Hello, everyone. Thank you for joining our enhanced therapy billing and Q&A for billing questions. Good evening to everyone on East Coast and late afternoon to other time zones as well. So appreciate you making some time on Halloween. I'm going to try to make this as quick as possible, but without compromising any information. However, you're always welcome to reach out to us, or you can reach out to me directly at steve@hellonote.com if you have any questions or if you want the slides that I'm going to show. And of course, we're going to record this so you can listen later. So let us begin. Before I begin, I do want to mention that we currently have a billing integration already built in. And this is more of our second iteration of billing, which means we minimized the work that you have to do even more. So I'll go over that. And if you currently use HelloNote for billing, you know that it's already pretty easy. Yes, you may need to log into the Clearinghouse, but overall, it's pretty easy. And with this enhancement, you actually don't need to log in to the Clearinghouse. Unless there's any errors, but I will go over all that. So let us begin our crash course on billing. So first, I want to start with some definitions and terminology. So you have to know what eligibility is. So a lot of those that are joining now, I've spoken to a lot of you, and you guys are doing self-pay. You don't deal with insurance. Which is nice, but a lot of you are struggling also with patients, not getting enough self-pay, cash-based patients, and you want to expand into the insurance world. And there's nothing wrong with the insurance world. Believe me, once you start doing it, you will actually pick up on everything because it's all recycled information. Once you do it once or twice, you are going to pick up, and it's the same thing over and over again. And of course, as you grow, you can definitely hire somebody or outsource to do everything. So eligibility is one of the most important things you should know. And that is because without checking eligibility, you may not get paid. So you don't want to spend your time seeing a patient only to bill the insurance and then realize that you couldn't see them. So eligibility is your ability to service the patient based on the insurance's regulations and benefits. To verify eligibility, you can call the insurance, you can use their own portal, or you can use an integration with an EMR such as HelloNote. We have an integration with a few clearinghouses. Check eligibility through there. If you do call the insurance, just make sure you have your group name or provider name, tax ID or social and NPI ready because that is required. Also, when you're checking eligibility, make sure you don't just check it once per year. Eligibility can change, especially with private insurances. You don't know if something's going to change in a week, in a month, in 6 months, and so on. Patients are always getting calls to change their insurance, especially now with Medicare Advantage being really prominent because it's cheaper. It's not a good option, but it's cheaper for the patient, and sometimes it makes sense for the patient. So make sure you're checking eligibility often. Next is benefits. The benefits refers to what services the insurance plan allows the patient to receive, as well as any other payments such as co-payments, co-insurances, deductibles, or anything else that might be present in the plan. Okay, some insurances don't have co-payments, but they have co-insurance. Some have deductibles and no co-insurances. Some have co-payments and deductibles and co-insurance. So you need to verify what benefits the patient has. Authorization. Some insurances may have or implement limits on how much visits that they are allowed in a certain year, for example. So this can be based on just total number of visits. So let's say they say only 10 visits of occupational therapy per year and 10 visits of physical therapy per year, or something like that. Now I've been seeing a lot more per unit limitations on authorization, which means they will tell you you have a maximum of 100 units per year, to bill, and they'll tell you which units those are. For example, 97110, 97530, and so on. Also, it can vary discipline to discipline. So OT, PT, speech can have different authorization limits. And be aware of start and end dates. So if you call the insurance and they tell you there's an authorization and they tell you that it starts December 1st and you see the patient November 20th, they're not going to pay you for that. And it's very rare that I've had any clients of ours ever tell me, including ourselves, that the insurance allowed them to get paid even though they were outside of the scope of either the start or the end date. So be very careful. You don't want to get caught in that trap. In-network versus out-of-network. So providers that are contracted with the insurance that the patient has, you are agreeing to pre-negotiated rates, which are discounted. So for example, let's say you're in-network with Aetna and they pay you $80 a session, for example. So usually you're going to get paid less than you would out-of-network. So out-of-network is that you are not contracted with that insurance and you don't accept their discounted rates, and usually that's reimbursed higher. So it's always a good idea to be out-of-network because the plan usually pays higher and you don't have to do credentialing. However, the drawback is that most plans don't have out-of-network benefits. So if you have a patient that does have out-of-network benefits, it's great. You can bill them. You still need to check eligibility, but at least you don't have to be credentialed with them. As for in-network, you need to make sure that you are credentialed with the insurance company. And credentialing, you could either do yourself or you can hire a company. We work closely with Billing Nerds, and they do a lot of credentialing for a lot of our clients and other services as well. So if you need a connection on that, reach out to us and we'll connect you. Next is deductible. So deductibles are amounts that the patient must pay before their insurance kicks in. So for example, let's say a patient has a $5,000 yearly deductible and you bill $150 per service, right? So you have to bill the insurance even though the insurance won't pay you until that $5,000 is met. And the reason is because if you don't bill the insurance, they have no way of knowing to decrease that deductible. Essentially, it involves all the other providers and services that the patient is going to see. So even though you're not going to get paid for those visits, you have to bill because the patient owes you that. Okay, and it's based on the max allowable of the insurance as well. And then once that $5,000 is met, and then all of a sudden you bill for, let's say, your 10th or 20th session, you're going to start getting reimbursed by the insurance, and then you'll know that deductible is getting met. And we'll go over ERAs and EOBs a little bit later, but on that EOB or ERA, you will actually see a line item that says the patient has deductible, that's why they didn't pay you. Next is copayment. So copayment is the most straightforward one, and that's just how much the patient pays every time they are seen for services. So for example, on their insurance card, it might say $10 copayment. Just also be careful because sometimes it says $10 copayment, but it's actually referring to like a physician. And then if you run eligibility, it's going to say they don't have a copayment for therapy. So you have to make sure that you're checking those benefits and eligibility. So if the patient does have a copayment, you just collect that up front. And just some words of advice, don't allow the patient not to pay every session because that adds up. And then if they owe you a certain amount and they stop coming for therapy or whatever the case is, it's very hard to come after the patient and recoup all of that. So the best to be upfront right away with the patient as far as what benefits their plan has and make sure that there's a payment plan in place so this way you don't have to chase the patient to recoup what you're owed. Co-insurance. So this is the amount the patient is responsible for each data service billed after the insurance pays. So an easy example is if they have a 20% co-insurance, that means when you get reimbursed by the insurance, they'll pay 80%, and then you can bill the patient 20%. Okay, so again, on the ERA or EOB, it will state a line item with patient responsibility, so you can easily know what the patient should pay. Next is out-of-pocket max. So this is a combination of all the co-payments, deductibles, co-insurances that the patient has to pay per year. So once that out-of-pocket max is met, then the insurance will start paying you. Next, Superbill. So a Superbill is a detailed invoice outlining the services a client received. So if you look on the right side here, this is called a CMS 1500 or a HCFA 1500. They used to be separate and then they kind of blended in, and now they're the same form. So this is a form that details all the billing data, including the patient's information and insurance number, date of birth, everything about the patient to make the claim reimbursable. Okay, so a lot of you I know have seen this form, and if you have not seen it, or even if you've seen it and never did anything with it, it looks overwhelming, but essentially it's just asking for all the details of the patient's it's more of the insurance and payer ID number and what services you billed and PI numbers and all of that. But it's not intimidating because with the billing integration, this is actually getting filled out for you electronically. So you actually don't need to fill anything out here once you follow a few steps, clicking a few buttons, and everything pre-generates, and we'll go over that a little bit later on the slides. So the CMS 1500 form here is for Medicare B services, including any private insurances. Then there is also a UB04 or a CMS 1450, which is similar, but it's about double the size and length, and that's used more for Part A services, including hospitals and surgery, radiology, and all of that. So if you're just billing outpatients, then you just need the CMS 1500. If you're billing Part A for whatever reason, then you use the UB04. And both are supported. We actually recently built out an integration for UB04, so we're testing that now because we do have a lot of home health clients as well that want to use the system. Next is Clearinghouse. So the Clearinghouse is the medium between the practice, which is you, and the payers, which is the insurance. So essentially, the Clearinghouse holds all the data, and then they take that data and they collect it from you, and then they flow it over to the payer. And then once you get paid, the data is sent back to the Clearinghouse, and then they can give you your ERA electronically and so on, tell you if you got paid or not. So there's also something called an EDI, which is electronic data interchange. And this is a process that's required by some insurances to allow you to submit claims electronically. Some insurances do require enrollment before you can submit the claim. So for example, Medicare B, traditional Medicare B, every single state requires an EDI. So you cannot submit claims to Medicare without the approval of the EDI. Then you have the ERA. So ERA is the electronic remittance advice, which is pretty much the electronic version of an EOB, explanation of benefits that you receive in the mail or through a portal. So it just makes things easier and more clear cut because everything's more organized. Then we have electronic funds transfer, which is called an EFT. So this actually allows the insurance company to send you a direct deposit. That's really all it means. But the Clearinghouse is not involved here. A lot of times I get questions of, oh, I didn't get my payment electronically. Contact the Clearinghouse and figure out why. Well, it's actually not the Clearinghouse that takes care of this. This is between you and the insurance. So usually you'll need to fill out a form and send it to the insurance, and then they will make sure that everything on the form is accurate. So this way they can direct deposit you your money that you got paid. But the good part is that the ERA will still come in to the Clearinghouse, and you'll be able to read why you got paid, what you got paid. So I highly recommend doing EFTs for all insurances that you bill. Next is Payer ID. So Payer ID is just a unique identification of the insurance company that's required for electronic billing. So think of it as a routing number, like your bank has a routing number. So same thing here. So insurances have a unique number It's sometimes made up of just numbers or just letters or a combination of both. So be careful because some insurances have multiple payer IDs going to different plans. So for example, like United Healthcare, they have a lot of different plans. And if you choose the wrong payer ID, even though the patient has United Healthcare, it can go to the wrong plan and then you won't get paid until you fix that. Okay. So next is how to run eligibility using the integration. So this is actually a new feature that HelloNote built out with a vendor. So with this feature, you can actually run Medicare and private insurance eligibility with a click of a button, which is really awesome because typically a lot of times I know providers call the insurance or they have to use a portal that doesn't save data and it just takes a long time to do that. So with our integration here, with a click of a button, you can see a Medicare eligibility. And if you look on the left here, so this is an example of a Medicare eligibility. Of course, this is just dummy data, but it actually tells you the entitlement dates, which are the effective dates of Part A, Part B. So notice Part C is blank. So Part C is actually Medicare Advantage. Okay, so just be careful with that because Medicare Advantage is not traditional Medicare. It's just the Advantage plan, which is a private insurance like Aetna, Humana, that's taking over the Part B benefits, and Part D, which is the pharmacy. But what I really like here, and what I know a lot of other of our clients are looking forward to, is making sure there's no home health in place, which it does show you that. It also shows you how much OT, PT, and speech has been used, any deductible amounts, and primary payer. So really important information here. If you look down, another important one that may be important is maybe immunization or something like that. But overall, it gives you all the necessary details if you can or cannot see the patient. Okay. And then on the right side, here's an example of a HMO PPO eligibility check. In this case, it's Fidelis. So it's going to tell you if there's any in-network co-insurance or copay and so on. Okay, so, and again, every private insurance typically has their own portal. So you can compare the data with their portal just to ensure that everything's accurate. But for Medicare, I think this is a really big deal. It's going to help a lot with time saving and just making sure that you're running eligibility more frequently. Because a lot of times I know providers typically they don't check eligibility often just because it consumes so much time. With this feature, it's going to save you so much time because with the click of a button, you run it. And then with another click of a button, we can upload it directly to the patient's chart. So you really have no reason not to use this if this is a feature that you have added to your plan. So next is how to submit claims electronically. So again, if you currently use HelloNote for billing, a lot of this you will most likely know this already until we get to the last tab, which is the submitted tab, which is where the enhanced integration comes into play. And if you don't use HelloNote for billing, then this is definitely something to pay attention to because I know a lot of providers are always hesitant about dealing with insurances because of exactly this portion about billing. They don't want to learn to bill. Believe me when I tell you, we have so many clients that have never touched billing, and with our system, they do their own billing. And when we speak to them, they don't want to outsource. They just want to do it themselves because they just feel so comfortable with it. So if you do have any questions and if you do want to see just a demo of how the billing works separately, then reach out to us and we'll be happy to show you. So the first slide here is how to input claims. So if you use HelloNote for documentation, which I know many of you do, you don't have to do anything more than do your documentation. Okay, so the CPT codes, all that will already be generated and you're good to go. Now, let's say you, for whatever reason, do notes on paper or, let's say you use another system for notes, whatever the case is, and you want to put in billing data here. So you can actually generate a billing note. So if you generate a billing note, notice it's only asking you for treatment diagnosis, the treatments you performed today, including the units, and that's pretty much it. I mean, all the other information is in the patient information tab, so it's going to pull that data from there. And once you save this, it's going to generate you a billable claim, okay? Because I do work with, there's not many clinics that still do notes on paper, but we do have a handful of clinics that do notes on paper. And for them, this is a lifesaver because before they had to spend hours doing billing, whereas here they just generate a billable note, put in the CPT codes, save, and they're done. So, and remember that the MS 1500 form is automatically generated. So there's really nothing more to do than fill out either this form or do your notes. So next is how to generate your claims to prepare them for insurance submission. So with the Ready to Send tab, here you're going to generate all the notes that have billing data, including any notes that you did or those billable notes that I just mentioned in the last slide. Okay, so really important, you're not going to have any claims here generated if they're in draft or pending cosign. Okay, any notes in draft are not considered billable. Same thing for pending cosign. They're not considered billable yet until they're cosigned. Quick discharges, communication notes, any notes that you did and didn't put any units for, those are not billable either. So you're only going to be left with claims that have billing data. And if you look at the column that says CPT code, then you can see here all the modifiers are there, including which CPT code along with how many units. Okay, so once you audit the claim by clicking the button on the right or clicking Batch Audit on the top right, any claims that are missing data you will be alerted for. So this is called scrubbing. It's going to scrub the claims, and any claims that are missing data, it's going to tell you, hey, you're missing, for example, here it says patient street address, city, state, zip code, and so on. So let's say you forgot to put in the patient's insurance number. You don't want that claim to go to the insurance company just to get a denial. So we flag it for you before it hits that step. Okay, and anything that does pass the audit, then it goes to the next tab, which is called the Audited tab. The Audited tab are just pretty much a collection of your clean claims. Okay, so once a note is successfully audited, then you can upload it to the Clearinghouse. And I know I know it's really preference of the clinic. So you may want to bill every week or twice a week or every Fridays or once a month. It really depends on your clinic. And from our side, there's no limitation. You do your own billing just by simply clicking a few buttons, so you're in control of your own frequency. Okay, so you can also scrub claims every Monday or every day, and then every Friday you release the claims to the insurance company. Or you want to just scrub claims and release them every second Friday or something like that. It's really up to you. But again, everything is just with click of a button. Okay. And yeah, you could do it at your own frequency. So once the claims are sent to the insurance, so once again, you can upload them as a batch by clicking Submit Claims on the top right, or you can click this second action button to do one by one. There's really no reason to do one by one unless you're, I guess, learning, or maybe you want to submit one claim. But otherwise, batch is probably the way to go and how most clinics do it. So once the claims are audited, they then get transmitted to the Clearinghouse. So here is where the new integration comes in. And for those of you that did not use HelloNote before, the integration we have now doesn't allow for claim status. So what that means is claims go off to the Clearinghouse, but you just have to log into the Clearinghouse and release them from there and pull the status. So with the enhanced Clearinghouse integration here, we are taking it to the next level and a step forward by pulling the claim status for you, and you don't even need to log into the Clearinghouse, which is an awesome time saver on top of the time you already saved by doing billing. So just to go over a few of the claim statuses, so we have error. So if you see anything in red, error, it's going to tell you there's something missing from the clearinghouse side. Maybe the payer ID number was there, but maybe the payer ID number was wrong, and the clearinghouse will flag that for you. Then we have pending. So if a claim is still en route to the clearinghouse, it may say pending. Transmit lets you know that there's no errors on the claim and it's going to the insurance company. So you just got to give it a little bit of time. Usually it's about 12 to 48 hours, depending on the insurance company. And then once it's successfully read by the insurance company, it's going to change to acknowledged. So once it's acknowledged, you know that the claim has already been received by the insurance. And then you wait for either paid or rejected. So if it's paid, that's great news. It's going to tell you how much paid. So if you look on the second to last row, for example, here, it says paid $94. So great. And then if you look to the right of that, notice that there's a $sign icon. So because you got paid, you can now click the $sign icon and post that $94 to the claim. Okay, and I do have a slide on posting. I'll go over that in a little bit. And then once you do post the claim, then it's going to change the status to posted. And then if you notice, under the paid column, it says 105. So it posted $105 to the claim. So it really saves a ton of time without you having to import, export anything, or log into the clearinghouse unless needed. So for example, if there's an error that maybe, as I mentioned before, maybe payer ID number didn't match or something like that, then you'll just log into the clearinghouse. And essentially, you shouldn't be getting errors in general. Maybe you'll get an error in the beginning. Maybe you submit it to an insurance company. They need something like a taxonomy number or something like that, which we can definitely add for you. There's rules in the clearinghouse, so we can set that up. But I would say 98% of the time, you should not be getting any errors, if even. Okay, so next tab. So what if there is an error or a denial? So if there is an error, you can put your mouse over the error status and the indicator will show you what the error is. So again, I think this is really cool. It doesn't only just tell you that there's an error. It actually allows you to put your mouse over the error and it will tell you what the error is. So in this case, it's telling you the Medicare beneficiary, ID number is invalid because it does have certain required parameters like mix of numbers and letters. So in this case, it's flagging it. The MPI number is wrong and so on. Again, this is all dummy data. So in a real case, you shouldn't be getting these errors, especially if you check eligibility. And let's say there is an error. It's okay. All you do is log into the clearinghouse at that point. And you could see here there's highlighted fields. So where it says in box number 1A, you update that to the correct ID number. And then box number 17A, it has zeros for the NPI, which of course is invalid. So you update that, you save the claim, and it's going to reprocess for you. Okay, and that's it. That's really all you have to do to fix an error. Next slide is a denial. So very similar. So I chose to go over, I'm showing you an EOB here, and I'm going to give you an example of how to fix a denied claim. So let's say you submit a claim to the insurance company, let's say it's Medicare, and then you get a denial back that states CO119. So this is a common denial for Medicare B, letting you know that maximum benefit has been reached. Okay, so what that means is that they're looking for a KX modifier. So HelloNote does have a flag automatically for KX. So we do the best we can to get that exact amount, but only Medicare has the actual numbers. So let's say you get flagged for it early. All you do is open up the claim, you add KX to the line item after the 59, or the GP, whichever one is in sequence. You save the claim, and it goes out again, and you'll get paid for it. So that's really it. For Medicare B, it's actually really easy to resubmit a claim. If it's a private insurance, you just need to put in the claim number. There's a box for and put a corrected claim ID. Again, this is all stuff that once you do it once, you're going to know what to do for the next time. And we are always answering billing questions either way. We have a great team of staff that are happy to answer your questions. So don't hesitate to ask or request a training if you need any help. So how to post back payments. So let's say you did get paid, right? What do you do next? So with the enhanced integration, we're adding a new item to the dashboard, which is called incoming ERAs. So with incoming ERAs, we're actually going to pull the ERAs from the clearinghouse and let you know that you're getting paid. So if we look here for example, on 10/26, there was a Medicare EOB with 3 payments totaling to $384.38. A day before, or the day before that, you got United Healthcare, and then you have Medicare with 2 payments, and so on. So you don't need to log into the clearinghouse now to know if you got paid. Same thing on the submitted tab of the claim page that we went over a couple slides back with that $sign icon on the right. So if you click that button, it will ask you, do you want to post this payment? And if you press yes, it's going to post that payment directly to the claim and then leave you with, for example, in this case, it's a $22.05 patient responsibility. And then, of course, you can print the receipt, give it to the patient, and that's really it. So next slide is, once the payment is applied, any outstanding balance can be printed as a statement. So if you're left with something like a deductible or coinsurance as patient responsibility, you can print that as a statement from HelloNote and give it to the patient. Or if they paid you, you can give them a receipt that says 0 balance. Also, secondary insurances sometimes come into play, especially for Medicare B. If you bill the primary, which is Medicare B, and then it gets forwarded to, United Healthcare, for example, for secondary, like with the remaining 20%, then you just need to wait for payment. Once you get paid, you go back in, you apply that payment, and the balance is 0, you're good to go. And then on the bottom here, you see you can apply your payments and run your reports. So reports are really important. Make sure you're running them just to see how your clinic is doing. So in this example here, we ran it from July till today, and you can see here, all the payments that were collected, including total revenue. So again, it's really important to run reports because as the months and years go on, you can really take a look at your clinic to see which are your best months, your worst months, where you need improvement, and so on. And congratulations, the revenue cycle is complete. So that is really from start to finish of billing in a nutshell. So we started with eligibility checking, then we're collecting the copay and the balance, we're creating the claims, we're correcting any errors or denials that can happen, we're doing a claim follow-up, we issue a statement to the patient, we collect the payments, and we run the report. So that's really it. Again, I know if you never did billing before, it might seem overwhelming, but once you try it, it's not that bad. And I always recommend to everyone, even if you do want to start billing insurance, I have so many clients that they have never billed insurance and they're about to bill and they hire a biller without understanding how the RCM, revenue cycle management, works. But I think it's important to know. It's fine to outsource a biller for you. There's nothing wrong with that, but at least understand the process that goes into it, because you'll have a lot more respect for your biller, because sometimes there's so much more that they do than you think, and there's no kind of discrepancy or miscommunication because you'll outline all the responsibilities between you and your biller. But then I also have majority of our clients, they do their own billing, whether they do it themselves or they hire someone in-house to do it, but at least they understand it. They all started with doing billing, so I definitely recommend learning the process of billing. And then we collected some questions from many of you that wanted to join this presentation. So I want to go over the top 10 questions we received. The first one is, what is the difference between HMO and PPO? So if you remember on the first slide, in-network versus out-of-network. So an HMO, you have to be contracted with the insurance and accept their discounted rates. And a PPO could be the same insurance, but the patient usually pays a higher premium, and it allows the provider, including yourself or any doctor, to see them without any limitations or credentialing. So if you're not credentialed with an insurance and they have out-of-network benefits, usually they have a PPO and you can see them. But if it says HMO on their card, you want to be careful here, and you see them and they don't have out-of-network benefits, you're not going to get paid. So make sure you check eligibility. Next one is, my patient has Aetna Medicare Advantage. Can I bill them? So going back to credentialing, once you see Medicare Advantage, don't think that it's just Medicare, because that's a lot of you I know have been caught in that, where you're credentialed with Medicare in your state, whether that's NGS or CMS, whichever MAC that you belong to, and you get a P10, and then you have a patient that you get a referral for, you start seeing them, you bill them, and then you get a denial that they can't find you in their system, and so on. And that's the reason is because you're not credentialed with that insurance, and the patient has an HMO plan, because Medicare Advantage it's just a private insurance that's taking over the Medicare contract. Okay, so be careful with that. So if you want to get credentialed with that insurance, it's fine, you can, but you cannot see them if they have an HMO, Medicare Advantage, and you're not credentialed. How do I know if an ICD-10 is billable? So this is a good question, because sometimes you choose ICD-10 codes and you get a denial because that ICD-10 code is not billable. So I use a website, and I know many of us use a website called icd10data.org. So this website, you can put in an ICD-10 code, and it's actually going to tell you if it's billable or non-billable. And they do a really good job also with updating. Usually every October or beginning of the year, there's changes to ICD-10 codes. So they do a really good job in making sure everything is up to date. And we also use them to update our system for any billable, non-billable codes. So in our system, you're actually going to see it's going to show red for non-billable or green billable when you're choosing codes. So that's how you know if it's billable or not. Also, if you do bill an insurance with a non-billable code and you have more than one diagnosis code, maybe you want to switch the order of that. So this way the billable one is first, which is primary, and you still can get paid. Number 4, what should I ask when I call to verify eligibility? So if you're calling to verify eligibility, one thing I always recommend asking is who you're speaking to. Because you don't want to speak to somebody and then they give you some eligibility and then you find out something's wrong. So you want to make sure you speak to that person again and you have a reference number of who you spoke to. So always ask. I personally always ask to get a fax of the eligibility. So on top of getting a verbal confirmation, I want to get a fax, or I have not had any insurances offer email, but most of them that I deal with offered fax. So there's going to say any co-payments, any authorizations, deductibles, and so on, or limitations, including authorizations. And ask if there is an authorization. Ask also what's the start, what's the end, how many days you have to submit the claim. Because I know it doesn't happen often, but if you hold the claims for too long, then you're going to get a denial due to timely filing. because some insurances only give you 90 days, some give you 180 days. Traditional Medicare gives you a year, which is great. But make sure if you're calling for eligibility for private insurance, you ask. Also, I would definitely recommend asking if they follow Medicare guidelines. So if it's a Medicare Advantage, usually they do follow Medicare guidelines, but it's always good to ask because you never know what plan they might have. Number 5, what if my claim is denied? So we went over that in a slide. There's no need to worry. The first thing you should do is understand why it's denied. Okay, I know we get a lot of clients that panic once they get a denial because they submitted a bunch of claims and they're not getting paid for anything. Always find out the reason for denial, because usually, especially if you did your due diligence with eligibility, usually those claims are all fixable. There's a reason that it was denied. And then you go into the claim, you fix it, you save it, it gets reprocessed, and you get paid. Okay, so don't panic, and we'll help you if you need any help. Number 6, should I do my own billing or outsource it? So again, I always prefer everyone to at least try to understand and do billing yourself before you outsource it. If you're doing your own billing and you find it to be easy and you're in control of the process and the system and you're running your own reports, and there's nothing wrong with that. But let's say you want to start growing your business, right? And even though billing might not be taking you that long, maybe it takes you 2-3 hours a month or something like that, if even, of course, depending on how busy you are. Then maybe you want to spend those 2-3 hours on marketing. Maybe you want to grow your business more. So in that case, it might be worth it to outsource. And you also have to do the math, because when you outsource billing, a lot of times you pay a percent versus hiring somebody, and then you pay them a salary, for example, and they do billing for you. So it might seem always like a good idea. You want to do billing in-house and hire someone. But if you look at the numbers, when you hire someone, you might have to pay them a higher rate, or you have to pay benefits and so on. So if you actually outsource it with a percent, it's actually going to come out to cheaper. And there's nothing wrong with switching. So maybe this year it's better to do in-house. Next year, outsource makes more sense for you. Of course, you don't want to keep changing all the time because it's your money. So whoever's doing billing for you is managing your money, right? So that's why I always say understand billing first, do it yourself, so you understand what goes into it. Number 7, what is the 59 modifier used for? So a 59 modifier is part of the NCCI edit, and it's owned by Medicare, actually. So it's a modifier that goes on. Recently, they actually allowed it to go on either or. It's always a bundle of two CPT codes. As an example, I'll give 97530, therapeutic activities, and 97140. So if you're billing those two codes together, then one of them needs a 59 modifier, because that tells the insurance that you did the treatments, they were separate from each other. So it kind of indicates that it's a separate service and it should be payable in addition to the other code. Because for whatever reason, those two codes, as well as some other bundle of codes, Medicare decided that there can be overlap in service, and they don't want to pay you twice for the same service. So that's where the 59 modifier comes in. Again, the good news is that HelloNote does it for you. So we automatically apply the 59 modifier where it's needed, and the Clearinghouse does it as well. You kind of have like 2 checks on that. How long does an EDI and ERA take to process? It's been over a week. So it's a common question we always get is my EDI is processing, but it's been a week, 2 weeks, and so on. It really depends on the insurance. Like Medicare, I usually like to give it at least a month, just because for every state, I always notice that it takes longer for Medicare, whereas if it's a private insurance, it can be done in a week, 2 weeks, and so on. Very rarely I see it EDI go through in a couple of days, but it does happen. Also, if you call the insurance company and you tell them I submitted an ERA or EDI, they may click a button on their end and approve it for you. So if you're in a rush, you can definitely do that. I've definitely had plenty of clients that did that, and it worked. Number 9, how do I find the payer ID of the insurance? This is a great question because payer ID number is extremely important to get correct. Number 1 is we can provide you a reference sheet. However, remember, it's always good to find out directly from the patient side what the payer ID is, because there may be multiple plans with the same insurance. Unfortunately, not all the time it's on the insurance card. It's actually rarely on the insurance card for some reason. But if you find it on the insurance card, like front or back, perfect. If you don't, then I recommend just calling the insurance, giving the member ID number, your MPI, and all that, and they will give you the payer ID number, and you can get eligibility at the same time. So definitely try to get the payer ID number correct. Yeah, that's important. And number 10, can I charge a patient cash if I'm not in network with their insurance? Another great question, because a lot of times I have clients that start seeing patients cash, and these patients are Medicare and they're actually credentialed with Medicare. So no, you cannot charge a patient cash if it's a Medicare patient and you're credentialed with Medicare. However, if it's a Medicare Advantage plan and you're not in network with them, then, and you don't accept their rates for whatever reason, then yes, you can charge the patient cash. Just be careful, because also if the patient has like Medicaid plans or something like that, you're not allowed to charge them cash either. So it really depends on the plan. Also, I've heard, some states have different rules on this. But overall, if the patient has a private insurance, including Medicare Advantage, and you're not credentialed with them, then yes. But if it's a federal insurance or a state plan, then no. However, again, there's different rules with states. But if you need more information on that, we do work with some great mentors that can answer that. Actually, there's going to be a live event in Florida, in Siesta Key, in about a week and a half. So there are 5 spots left. I spoke to Kara Welke. She's organizing it. She's amazing. She always has a lot to provide, whether it's online or in person. I'm sure it's going to be a blast, including it just being packed with fun activities and informational stuff. So I personally wouldn't want to miss it. That's why I'm going. I know a lot of people are already signed up. There's only 5 spots left. And again, I'm not saying there's 5 spots left just because, want to fill up spots when there's more spots. It's actually really limited to 30 attendees, and there's only 5 spots left. So I definitely recommend inquiring about that. If you, and we have a discount for $300 off. So you can shoot us an email. You can send me an email at hello@hellonote.com or steve@hellonote.com. Mention that you're interested in the event, and we'll hook you up. We'll set it up for you. And yeah, that's pretty much it for the presentation. So again, thank you everyone. Appreciate your time and spending a little bit of Halloween with me here and the HelloNote team. And if you do have any questions, again, even if you're not using billing with us, but you do want to learn or have questions, reach out to us. We're always happy to help. And we will be sending out this recording to everyone that registered, including the slides. So look out for that. Otherwise, thank you, everyone. Have a good evening and appreciate your time and looking forward to working with you. Thank you.